This explainer is based on the literature review, Enlarged Vestibular Aqueduct, a vestibular physician's deep review of congenital inner ear pathology, hearing loss, and management, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Welcome back to the Explainer. Today, we're diving straight into a highly structured, evidence-based diagnostic pathway for enlarged vestibular aqueduct, or EVA. If you're a vestibular physician, a neuro-otologist, or an advanced practitioner, mastering this pathway isn't just a nice-to-have, it's absolutely essential. We're not just looking at a simple anatomical quirk here. We're talking about a condition where precise identification literally prevents serious long-term developmental and systemic consequences.
Okay, let's look at our clinical roadmap. We're going to start with a paradigm shift in diagnosing EVA, look at specific radiological criteria, and compare CT versus MRI utility. From there, we'll unpack the audiovestibular workup, detail the genetic and endocrine protocols, and wrap things up with our next steps.
Right, Section 1, the paradigm shift. For a long time, we kind of had this tendency to view EVA as simply a finding on a radiology report. Just check a box and move on, right? But modern clinical consensus demands a major paradigm shift. While EVA is absolutely defined radiologically, stopping at a single CT measurement is, quite frankly, a clinical failure. Why? Because that one structural finding has to trigger an immediate cascade of targeted rehabilitation, genetic testing, and endocrine interventions. That anatomical enlargement, it's really just the tip of the iceberg. It's the gateway to a massive, systemic, multidisciplinary diagnostic pathway.
Section 2, Radiological Criteria.
Okay, I want you to literally burn this clinical pearl into your memory. If you have a child presenting with progressive sensorineural hearing loss, combined with an unexplained air bone gap and a perfectly normal tympanogram, you must image the temporal bones. This specific triad is EVA until proven otherwise. The literature clearly shows that failing to image patients presenting with this exact triad is the single most common diagnostic error in EVA. We simply cannot afford to miss this. Now, what's really fascinating here is the contrast between our historical standards and modern best practices. On the top row, you'll see the original Valvasori criterion from 1978. That defines EVA as a midpoint diameter greater than 1.5 millimeters. And hey, that's still useful for adults in historical research. But look right below that. We have the modern Cincinnati criteria, which defines enlargement as greater than 1.0 millimeter at the midpoint or greater than 2.0 millimeters at the operculum. The Cincinnati criteria are way more sensitive for the pediatric population. This is our current operative standard. So here is the crucial takeaway. Always check which criterion your radiologist actually used. If you get a report back saying no EVA based solely on that older 1.5 millimeter Valvasori threshold, that report could completely miss a Cincinnati positive child whose aqueduct measures, let's say, 1.2 millimeters. If your clinical suspicion is high, especially based on that triad we just talked about, you need to push back. Urge the radiologist to provide explicit measurements and actively apply the Cincinnati criteria. Moving on to Section 3. CT versus MRI utility. And this brilliantly illustrates just how complementary these two scans really are. On the right, we've got a high-resolution CT at 0.6 millimeter slices. This is absolutely the definitive standard for mapping out the bony architecture of the canal. But on the left, the MRI T2 sequence does something the CT simply can't do. It directly visualizes the soft tissues. It clearly delineates the enlarged endolymphatic sac, the duct, and crucially, it lets us assess the cochlear nerve. MRI is incredibly relevant here, especially when you need to exclude cochlear nerve aplasia before potential cochlear implantation or when you're checking for co-occurring Mendini dysplasia. All right, Section 4, the audiovestibular workup. This brings us to the core of the workup, the highly structured 4-pillar assessment protocol. These pillars are audiological, vestibular, imaging, and genetic endocrine. This framework is exactly how we take a static radiological finding and transform it into a comprehensive, dynamic care plan. So let's break down the functional testing pillars first. First up, the audiological battery. Pure tone audiometry is mandatory to capture that classic low to mid-frequency sensory neural loss. And of course, we use ABR, auditory brainstem response, in infants where behavioral testing just isn't possible. But pay close attention to the bottom 2 points. Tympanometry and acoustic reflexes are absolutely essential here. You need them to definitively document the characteristic air-bone gap caused by the third window effect of the enlarged aqueduct, all while confirming that middle ear function is completely normal. Next is the vestibular battery. Now, EVA is often thought of strictly as a hearing loss condition, but the literature reveals a whopping 40 to 45% objective vestibular abnormality rate in these patients. That is huge. Because of this, a specific testing battery is absolutely critical. We use video head impulse testing, focusing heavily on the horizontal and posterior canals, alongside bithermocalorics, cervical and ocular vents to check the otolith organs, and VNG. These tests don't just diagnose the issue, they're fundamentally required for predicting the patient's balance trajectory and mapping out their targeted vestibular rehab. Section 5. The Genetic and Endocrine Protocol. To really grasp why genetics are so critical in EVA, we have to talk about Pendrit syndrome. It is the most common syndromic cause of congenital deafness worldwide. It's an autosomal recessive condition characterized by bilateral EVA, sensory neural hearing loss, and thyroid dysfunction, specifically a goiter, caused by biallelic mutations in the SLC26A4 gene. Missing this syndromic diagnosis is a massive clinical error. Why? Because it has profound, lifelong implications for the patient's thyroid monitoring, not to mention genetic counseling and screening for their entire family. Because SLC26A4 is so heavily involved, our genetic testing pathway has to be highly structured. Step 1 is first-line full gene sequencing of SLC26A4. This brilliantly identifies the causal variant in up to 70% of even non-syndromic cases. If that comes back negative, step 2 is a multi-gene next-generation sequencing panel, looking at loci like FOXI1 and KCNJ10. Steps 3 and 4 ensure that this complex data actually translates into real patient care through formal genetic counseling and family cascade testing. Remember, there's a 25% recurrence risk per pregnancy for these autosomal recessive traits. And tied directly to that genetic reality is a very strict clinical mandate. Endocrine surveillance is completely non-negotiable. Because of that powerful link to Pendrit syndrome we just discussed, thyroid function tests, specifically TSH and free T4, belong in the diagnostic workup of absolutely every single child diagnosed with EVH. And that is for sure, regardless of the severity of their initial hearing loss. Finally, Section 6, Summary and Next Steps. This chart beautifully summarizes our entire goal for this workup. By running the 4-domain battery, applying those precise Cincinnati criteria on high-res CT, delineating soft tissue with MRI, and completing all of our functional and genetic endocrine testing, we finally arrive at a confirmed, actionable clinical pathway. The patient gets a tailored audiological monitoring plan, vestibular rehabilitation therapy if their tests are abnormal, clear steps toward the cochlear implant pathway if required, and comprehensive genetic counseling. Which leaves us with a critical question. We now have our highly structured diagnostic and genetic baseline firmly in place. But how do we actually manage the notoriously fluctuating trajectory of hearing loss and balance that these patients face over their lifetime? Well, in part 5 of this Explainer series, we are going to cover exactly that, management, including monitoring, hearing rehabilitation, and cochlear implantation. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this Explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series.